بسم الله الرحمن الرحيم والصلاة والسلام على محمد رسول الله وعلى آله وصحبه وله. I hope you all are well. We're going to be discussing urinary tract infections today, inshallah. Everything related to it, from the pathogenesis, the risk factors, as well as the different causative agents, inshallah. Introduction. What are UTIs? They are any microorganisms, usually bacteria, that can cause an inflammation or infection of the urinary tract, and that can include the urethra, the kidneys, renal pelvis, or even the bladder. Normally, in a healthy urinary tract, the bacteria are going to be destroyed by the natural resident flora that are found, maybe the pH and the sterile urine. However, obviously, as we'll discuss in the next slide, there are certain risk factors that can predispose to these. And it's worth keeping in mind that catheter-associated CA urinary tract infections are the leading cause of healthcare-related infections. So you'll commonly see them in the hospital. Some of the predisposing factors for UTIs. First and foremost, the female anatomy, as we'll see in the next slide as well. Basically, being a female, meaning that they're going to have a shorter urethra, and therefore the microorganisms can easily ascend upwards and reach the urinary bladder and other parts of the urinary tract. We can have urinary tract abnormalities that can range from, again, obstructions or blockages that will disrupt the normal urine flow, as we can see. Sometimes even incomplete emptying of the bladder, meaning you don't completely finish your urination. You stop midway and then leave. That can predispose. Pregnancy, again, because of the added weight that can compress the ureters. Very, very common. Sexual activity, as we'll see also. Saprophytitis being a very common cause of the sexual activity, calling it the honeymoon cystitis, yes, because of, again, what sexually transmitted infections could be from the urethra because of the contact. And obviously other comorbidities, being immunocompromised, can easily facilitate an environment for the microorganisms to attack. To expand on what we mentioned with regard to the female anatomy, we can see, again, having a short urethra is going to make it easier for the bacteria to invade, because it is going to be within close proximity to the perirectal region. Again, that is going to contain a lot of pathogens and microorganisms, and therefore allows the bacteria to reach the bladder more easily, in contrast to males that have much more or less common, because of what the extra urethral lengths that prevents the bacterial colonization, and it gives it basically more time to eliminate the infection. And similar idea, like we said, sexual intercourse is going to increase. Why? Because there will be sharing of sexually transmitted infections between the two people when they come into contact. We'll be discussing the 5 most common bacteria that cause UTIs, 4 of which are actually gram-negative bacteria, and only Staphylococcus saprophyticus being the gram-positive. We'll discuss high-yield information about each and how you can identify and distinguish. But always remember that E. coli is going to be the most common causative agent. So starting with E. coli, Klebsiella, and Proteus. First, we can start by grouping E. coli and Klebsiella together as lactose fermenting. Again, this will be highly characteristic to remember what they look like on a culture agar plate. E. coli, specifically the UPEC, uropathogenic E. coli. We've discussed other variants in previous videos. So this is the one that's going to be seen in UTIs, obviously, pili and fimbriae, meaning it is going to be motile. And remember the characteristic, again, findings that it will produce biofilm. And remember, lactose fermenting will give this characteristic appearance. Klebsiella, on the other hand, is going to be non-motile. That's worth remembering. It will have a capsule that will help it produce this mucoid appearance. Again, high yield. Remember these information, the small details, and what it looks like. And finally, for Proteus, as we'll see, as well as Pseudomonas, both are going to be non-lactose fermenting. Again, this will be useful in a few slides, we'll see. Something that is highly characteristic of Proteus is that it will produce a swarming motility on the culture. We can see as if you've dropped a pebble and it created streams around it. So this is highly characteristic of Proteus. It will produce large amounts of urease, therefore making the pH extremely high. So again, if you test the pH and you found that it is high pH, it could be highly indicative of Proteus. We can do the culture to confirm by looking for swarming motility. And because of this high pH increase, it can increase the risk of formation of kidney stones. Remember these information. Now on to Pseudomonas. As we've mentioned, it is going to be non-lactose fermenting, and remember, it is going to have a capsule, as most do. Now, something that I use actually to remember, again, Pseudomonas. So Muna is a 42-year-old woman that has a sweet smell, okay, and likes the color green. So, I mean, it's far-fetched, but you can use this to remember. So remember, again, Pseudomonas grows best at 42 degrees Celsius. It is going to produce greenish pigments. Again, we can see she's 42, so she's old. We can see that this kind of looks old and moldy, okay? Sweet, grape-like, fruity odor, and is going to be also what? Oxidase positive, highly, again, yield. Also, like others, produces a biofilm, again, and obviously is going to be primarily seen with what? Those with long-term indwelling urinary catheters. So again, from this case, they can tell you that a patient has been, on urinary catheter, uses basically for a long time with isolated bacteria that has these characteristics. What could that be? Again, you go for Pseudomonas. And finally, the only gram-positive amongst the 5 is going to be Staph saprophycetus. Again, we know this as part of what the staphylococci chains. We know that they're going to be what? Catalase positive. They're going to be coagulase negative. And then to differentiate between saprophycetus and epidermidis, we do the novobiocin sensitivity test, and it's going to be negative, as we'll see in a bit. Remember, it is going to be the most common wear in those with young females that are sexually active, usually in the honeymoon, so what we call the honeymoon cystitis. So it is the second most causative agent of acute UTIs, but usually always associated with what? Honeymoon UTIs, all right? Young, sexually active females. So now, as a quick run-through that's more related again for OSPE, but generally speaking, remember we use the McConnachie agar for gram-negative in general, as opposite to the blood-sheep agar in gram-positive. Remember, 2 lactose fermenting, E. coli and Klebsiella, characteristic pinkish appearance, in contrast to the non-lactose fermenting. Again, they're going to be colorless, Proteus and Pseudomonas. We said that the only non-motile is going to be Klebsiella, otherwise all are motile. Remember the mucoid colony, characteristic of who? Once again, Klebsiella. The swarming motility, remember Proteus, the pebble. The greenish pigment, again who? Muna, likes the color green. And finally, we mentioned both urine positive, high pH. Proteus is going to look something like this. Again, this is what we call a urea agar. And in response to change in pH, it will change colors as well. The oxidase positive says this is what it looks like. Basically, when you apply the bacteria, it should turn blue if it is positive. Again, remember, greenish pigment. And finally, in conclusion, I wanted to add how we obtain urine specimens usually. There's what we call the midstream urine sample. Again, that is going to usually be collected from bags. We don't ideally opt for that, but if we have to, we take what we call a midstream urine. So you don't take the urine at the beginning and neither at the end. Why is that the case? So that we can reduce the basically chances of contamination, because normally the urine that comes out first is going to be filled with what? Again, urethral bacteria, and the one in the middle is going to be the closest thing to the urine coming from the kidneys. Sometimes, again, we can also insert a catheter, again, but usually we will try to, as much as possible, not have to, because again, they can lead to increased risk of what? UTIs. The longer it is, the longer we have, like we said, the catheter-associated urinary tract infections. And sometimes we can resort to what we call a suprapubic bladder aspiration. This is going to be done usually when catheterization is not an option. You basically insert a needle at the suprapubic region, and you directly basically take a urine sample from the urinary bladder. And this is usually highly, selective. Finally, when you obtain your urine sample, obviously it must immediately be sent to the lab, because we don't want it to become warm, again, which can provide a very ideal environment for the bacterial growth. And this was it for UTIs. سبحانك اللهم وبحمدك أشهد أن لا إله إلا أنت أستغفرك وأتوب إليك. See you again in another video, inshallah.